Hello and welcome to the fourth module of PHM 613. And for today's topic, we'll be discussing health financing and insurance. We have three learning objectives. First, we're going to describe the history of insurance in the healthcare system in the US, discuss characteristics of the insurance markets in general, as well as particular to the healthcare. And then finally, we're going to discuss the impact of moral hazard in the insurance marketplace. So, starting with conversations about the US insurance system. So, as you guys know, the US is one of the only high income country or very or at least in the global north that doesn't largely provide national coverage, universal coverage to its citizens. Most other countries, most other high income countries, have a universal component of their health financing while also providing sometimes additional services that come under insurance. In the US, is mainly the private insurance, and then you have some populations that are covered by some form of universal coverage, like the Medicare and Medicaid and stuff, and the VA. But largely in the US is more insurance based healthcare system. And the reason it's like that in the US, it's not because of the lack of trying. The US does not have a national coverage, not because there hasn't been several attempts to make that happen. They have been at least five of them, of the major ones that happen on a national level, beginning in 1929 with Theodore Roosevelt, and ending with Hillary Clinton in 1993. And all five attempts at a universal coverage all failed in the US. So we've kind of, at this point, see that the insurance system is going to be the how the US healthcare system is going to be operated in, at least for the foreseeable future. And as a result, we kind of need to understand a little bit, what's going on with the healthcare system, the health insurance system in the US. So, prior to the insurance system coming in, how healthcare used to be paid for in the US was out of pocket. You have the money, you pay the doctor. If you don't have the money, you don't pay the doctor. There were, of course, some doctors that were willing to provide services for free or in some form of charity, but for the most part, you those who could pay for doctor visits were those who were able to receive healthcare services. And so what that then mean that there were quite a number of people who then had to forego healthcare services until they were severely ill and they couldn't avoid it any longer. And so that was a problem. In order to mitigate for that, you had in 1912, there was a national convention of insurance commissioners that came together and decided to solve this problem of underutilization of services because of one's inability to pay. And they came up with this model, of a health insurance system that was, kind of modeling what was in existence in terms of insurance for other commodities. And this was something that states were able to kind of pick up. And the reason that the health insurance system was able to kind of hold and got a lot of people's attention was that at the time it was seen as being, very proactive step to be taken, and already insurance was something that was, not a new phenomenon at the time. Just being able to see how it could be applied for health and solve the problem of payment was something that was quite welcomed at the time. So in 1929, something major happened, and that was when the Texas State Teachers Union came up with the prepaid hospital insurance that had them paying 50 cents per month to a hospital, the Baylor Hospital, and that's system grew, evolved into the Blue Cross plan, and was something that got very popular and was replicated in several other states. And then what happened in 1939 was that some physicians therefore organized themselves and kind of did something similar to Blue Cross, but from this time from the provider end of it, and they became Blue Shield. So that's where you have the Blue Cross and the Blue Shield amalgamation. So then when in 1965, Medicare, Medicaid was passed into law, some chunk of people who had insurance were kind of moved out of there, and they began to, get their own. But the majority of Americans still needed private insurance in order to continue to receive healthcare service. So in 1983, we then had this prospective payment system, which was developed from the HMO Act of 1973. You can click on this link, it will kind of give you a little bit more information about the HMO Act. So one of the things about the PPS, system was that it came up with this fee for service module, whereby it has some kind of bundled payment for diagnosis. So you had some kind of diagnosis, like a list of diagnoses that had the same amount of money that were being paid for it. So that was what that happened. So with the PPS, something that happened with the healthcare system was that it quite drastically changed the way health financing was done in the US at the time, because it introduced things like documentation and coding, which is still being used at present. So what that was when the US really got into the system, whereby there's a lot of resources that went into documentation and coding of a service of every financial interaction with the country, with the healthcare system. That is still very much in place today, whereby you have, depending on how a healthcare service is coded, this the insurance company may decide not to pay for it, or may decide to pay for it, and stuff like that. But that was where that came from. The PPS, that's where that came from. In present day, PPS is still very much in operation, but it kind of functions a lot more in the financing of Medicare payments. That is where you still have PPS being very much operationalized at present. So at present, well, in the 20th century, the US has mostly, majorly, two competing payment models that is still being used today. You have the fee for service, and you have the capitation. So you can click on both links to give you a little bit of explanation about what fee for service is and what capitation service is. But regardless whether it's fee for service or capitation, both payment modules are more payer friendly than patient friendly, in the sense that the focus of either is to make sure that providers get the most money that they can for the services that they provided, a whole lot more than the quality of service that it is that the patient gets. And what this has done to the US healthcare system is that the US has this very fragmented and very expensive healthcare system, that a lot of money goes into administration, much more than other countries. And unfortunately, despite all of that, money that goes into administration, it does not lead to a corresponding outcome in terms of quality of services and healthcare outcome, health outcomes. So that is a challenge that the US still has, despite, the advances that it has made with technology and all of that. So now that we know that we are going to be in the insurance market in the US for quite a while, if you're going to go by a policy, we may need to understand a little bit about the insurance market. So, generally speaking, the idea of the insurance is that when you are buying the insurance, when you buy an insurance, what you're trying to do is some form of a risk averse thing you're trying to do. You're trying to make it such that should something happen in the future, some unforeseeable events, adverse events, you don't bear the full cost of that event of happening. That unforeseeable future is seen to be something that is very likely going to cost you a lot of money. But if you just spend a small, much smaller amount of money, should that thing happen in the future, you're not going to have to be responsible for paying up, you're not going to be responsible for bearing the cost of that thing that happens in the future. And for the people who are selling the insurance to you, the whole idea, the principle of it is to pool a large, have a large pool of uh, people that they're insuring, where the principle is that for the most part, a majority of the pool are going to be, having little to low utilization. And so that this way, even if few are using quite moderate to large of it, they still have enough to go around. If many people are going to be, pouring into the pool of funds, and just fewer people are going to be drawing out each time, there's still going to be enough money to go around for everybody, and still be able to everybody be happy, business is booming, everybody's healthy. That is a principle of the insurance market. However, when it comes to health, health kind of has a little bit of, difference in the way that health behaves. For one thing, when the kind of risk that is associated with health is such that you're not just, accounting for some of the, life challenges that may happen, like suddenly breaking your leg and something like that, taking a fall, or breaking your back. One of those risks that comes to one's health. You are also having to the some risk that comes from, taking the medication, whether the medication is going to, work or not, and maybe you're going to have to get into using an experimental drug or something like that. You're also having to deal with some of the cost that comes from treating the illness. And sometimes you may be kind of out of commission for a while as a result of, being on treatments, not being able to, do all the things that you need to do because you're temporarily ill. So those are some of the risks that comes with one's health. Um, but the thing is that you, as a person, or a person who is, taking out the health insurance, is not just trying to take action to reduce your risk of illness, in terms of taking vaccinations and avoiding healthy environment and leading, healthy lifestyle. But it just, by doing all of those, it does not, you know really reduce your risk of health in the same way as, you know uh, maintaining your car, keeping the speed lane, only using the traffic lights as it is needed. It's a little bit different from how health works. For example, you cannot really insure against bad health outcomes. Do remember that for a lot of health outcomes, a lot of it comes with genetics. Well, not a lot, but quite a number of it can come with genetics. So, just how much can you insure against those? And then another problem with, the health insurance is that a lot of it is very, very individualistic in its approach to health. If I stay healthy, I won't incur a lot of health expenses. What happens with that is that it completely ignores the part that social determinants of health plays on one's health outcomes. And this is something that it doesn't work in other commodities. Social determinants of health doesn't work as much in other commodities in the way that it happens in health. So that is one of the challenges to you know, ensuring our health. There's also the thing about that people do not generally self-insure by saving money. When it comes to health, for most parts, how do you save enough money for health? You don't know how what's going to happen, to what degree is going to happen. It's kind of a little bit difficult to save for health in the way that you wouldn't do it for other things. I do know that some employer um, based insurance do give you some kind of health savings account, but some of them are not rolling, which means for each insurance cycle, it ends and you can't save it till the following year. You're kind of saving insurance cycle by per insurance cycle. That's not a very sustainable way of saving, self-insuring. It's just really not. And then finally, how do you save enough for catastrophic health illnesses, particularly in a place whereby we know that technological advances in health has been the greatest contributor of the health cost? How do you save for that? You don't know what technology is going to happen in the future and how much more that could impact the cost of getting healthcare. So it becomes quite difficult just to save enough for those, huge catastrophic illnesses. So that's one of the challenges that that there is in with the health insurance. So and also another thing is a health services contract. Um, the difference in than other types of health insurance. Generally, the health insurance cover is more likely is unlikely to just be catastrophic events. You also have health insurance being, including reimbursements insurance for annual physical exams. You also have vaccinations, you have treatment for chronic conditions, and you have various types of routines. All of those come from insurance, and the demand for these services, they're not unpredictable, nor are they usually do they usually entail catastrophic levels of expenditure, but they're still all covered under health insurance that people still kind of have to pay for. Depending on it, there are some programs that allow you to get those services for free, but there are some plans that you have to pay some form of co-payments in it. Even if it's not a lot of money, you're kind of having some form of co-payment depending on what that is. So it's not a very ideal market. Uh, it's not an ideal commodity to put through the insurance system in the way that other non-health commodities are. So that is one of the challenges of health being treated as a commodity in the insurance module. So, moral hazard. So, one of the conversations that health economists have about health insurance is the conversation of moral hazard. So, moral hazard is a phenomenon that people's behavior are affected by their insurance coverage. Basically, it's trying to say that if you have insurance, then you would use it. If you didn't have insurance, you wouldn't use it. It's more or less like trying to say that when you have insurance, then let's just, for example, if whether you're going to be a little bit less you're going to be a little bit less careful about your health care just because you have a health insurance. So that is the long and short about the idea of moral moral hazard when it comes to health insurance. So the argument is that moral hazard comes out in place of either you have an increased demand for health services, or there's increased utilization of health services, whether or not one needs it. And then finally, you may have some services and you choose not to use it, and because it's free to you, you are kind of a lot less enticed to use it, because it's not going to cost you anything to not use it, and therefore you don't use it. And then what then happens is that you get too sick, and then all of that prevention, those free services would have given you, you don't get it, and now you're going to end up spending a lot of money. So those are some of the arguments that have been made on moral hazard. So in this diagram tries to kind of conceptualize how moral hazard uh, operates in the context of a healthcare insurance market. So in this, I'm trying to see if you can see very well. So you have uh, DO, you have D1, and you have D2. So the concept of moral hazard is that this is this is what it would be. Okay, I'm going to flip back. So per the hazard, it's saying that an individual demand for healthcare when he has no health insurance is the DO. And when the insurance company is paying 100% is D2. And but when there is a split in payments between the insurance company and the insured, it becomes a D1. I want to go back right and show you. So this is what's per this graph is saying. This is what it is when there is no insurance. So it's saying that utilization is kind of low, but once you put it to where health insurance is paying 100%, you have utilization that goes really high. But once there's a split in payment, like a co-payment, suddenly it comes to the middle. And the argument for this is that the reason it's like that is that the shift is not because the insured needed more service. They're just basically responding to the decline in their out of pocket payment. So, which means that they would have used less. So when they realize that somebody else is not, that there's some cost that is to them. So it's not because they need it less, it's just because they're using it less. I'm trying to put it in a way. So the argument is that when it's a D2, the need for the healthcare is just as is not reduced from when it is at D1. Is this, they have the same need, but when it's at D2, they are overusing the healthcare. But when it's at D1, they're using it just at the right amount, the right quantity. So that is the argument of the moral hazard. So by saying you want to kind of guard against the moral hazard by making it such that insurance company is not covering 100%, because when it's covering 100%, people would tend to overuse the service that is available. That is the principle of the moral hazard. The thing is that both patients and providers, it's argued that they have the same incentive to overuse or over provide service when there is a insurance. From the side of the provider, they're trying to get as much of their expenses covered, to make as much profit as they can be. So that is the whole thing. So, and uh, when there is a insurance or co-payment, the insurer therefore has to kind of reduce, kind of de-incentivize providers from offering to over providing, and patients from overusing, by making it such that they provide fewer services that the premiums can completely cover, and those that they now be more services that can be out of pocket payments and stuff like that. So that is the principle of moral hazard. So that's where we end in today's class. Please use the Q&A board to ask any questions if there's any part of this course, the class, or the assignment that you didn't understand. Do have a lovely day. Bye.